Good morning, good afternoon, good evening, depending on what part of the world you're in. Welcome to the Operation Smile COVID-19 Forum for anesthesiologists and ICU specialists. We have friends and colleagues here from all over the world. This time nobody had to travel to be together, nobody had to share hotel rooms, and no name game. Although, Bill, if there's time at the end, maybe we can still give it a go. Thanks for joining us, and a special thanks to our forum panel. The purpose of this forum is to share information regarding anesthesia and ICU management of COVID, particularly information relevant to low and middle income countries. When seeing the limited resources that we have here in the United States, it gives me chills to think about what my friends may have to deal with or are already having to deal with even more limited resources. And we are losing some sleep here thinking about you. So we thought that it might be a good idea to try to put together a panel to be able to share information, share ideas. So we've had what some might refer to as an info fusion happening over the last weeks or months regarding COVID, and it's been sort of like drinking from a fire hose. It's not clear what to trust and what to incorporate into our practices. Information is rapidly growing, changing, and a vast majority of you have been working with Operation Smile and our friends and part of the Operation Smile family for years or even decades. So this represents information exchange between known sources. This is a dynamic situation, and I just want to say that, with the changes that are occurring every day, we need to recognize that some of the information given in this forum could prove incorrect in hindsight. Let's go over quickly some rules of the forum. We need to keep microphones and video off at all time, even you, Bill. That will help with bandwidth and will help with background noise. If there are questions, please use the chat function in order to place those questions. And we may ask some of the audience to unmute at times in order to discuss those questions or to discuss your own viewpoints or share information with us. We have audience polls that will allow for the panelists to understand much better their audience, and it is possible that that data might even be used in future communications or even in publications if that's warranted. I want to quickly introduce the panelists. Dr. Kate Talinko is a pediatrician with an MPH and works for Corvus Health. She is a Operation Smile consultant, and she has expertise in health workforce. Dr. Gavin Jones is an anesthesiologist in South Africa, and he's one of our regional medical officers. Likewise, Dr. Charles Kabetu is one of our regional medical officers, and he works as an anesthesiologist at University of Nairobi. Ben Moses is an anesthesiologist and critical care specialist at the University of Virginia Health System. Susan Nablendo is a pediatric anesthesiologist and lecturer at University of Nairobi. Dr. Luli Gautama is an anesthesiologist at Hospital Los Andes and Hospital Especialidades Carlos Andrade in Quito, Ecuador. Dr. Mike Stabile is an anesthesiologist at TriStar Centennial Medical Center in Nashville, Tennessee, and has been part of the leadership COVID-19 response team there. He's a past chair of Operation Smile Anesthesia Council. And I'm George Politis. I'm the current chair of the Anesthesia Council, and I'm a pediatric anesthesiologist at University of Virginia, which you see behind me. We're going to start out with the first poll, which is just some general questions to the audience about your practice. Like we have about 20% from South America, 12% from Sub-Saharan Africa, maybe half participants either come from North America or Europe. Half are anesthesiologists, 35% do both anesthesia and ICU. And about 80% are working in hospitals that are either university or other. So largely a hospital-based group. But you can see as well that almost half have a private practice in addition to that. And half say that COVID is well underway. But there is a group of you that is noting that it is just at the beginning, and that probably is largely sub-Saharan Africa. So let's move into our first topic, and that's going to be Kate Talenko, speaking about workforce-related issues, and she's going to start out with a poll here in a moment.
So this is the health workforce poll that's up now, so please vote. So for the 3 questions, for the addition of new staffing, we see that the number 1 is of non-ICU physicians, which isn't surprising. And second after that is non-ICU nurses. And we know in most countries there is a shortage of the subspecialty physicians and nurses. And so how we take those ward physicians and nurses and bring them up to a standard of care for ICU for COVID is one of the big challenges. The second question here is on how you prepared the health workers. So preparing protocols, guidelines, and clinical pathways for COVID was number 1, followed by face-to-face or online formal training. And definitely what we're seeing is that there isn't as much formal training as people would like. And it's important to give that formal training not only in the beginning when someone first starts working with COVID, but in touches, maybe weekly touches along the way to increase people's skills, especially as how we treat COVID changes so rapidly. And then the third and final question was about the supports that are offered to staff. And number 1 was increased communications and check-in, followed by mental health support. We know that there's a lot of evidence from the SARS outbreak that post-traumatic stress disorder and other mental health issues were quite high in health workers that had a considerable exposure to the SARS outbreak. And so we see also facilities providing food and lodging near hospitals. That's particularly important during the peak of the surge, when people are often unable to go home because it's just too far difficult. They're working too many hours, or they don't want to go home because they're afraid of infecting their families. Okay. So Megan or Ali, if you could put my slides up. So while we're waiting for that, I'll start. So as George mentioned, I'm a physician and health workforce specialist, and I'm the former director of the U.S. government's Global Health Workforce Program. And Ali, could you advance 1 slide, please? And Operation Smile, in order to help our partners with the COVID response, has created a 4-page surge capacity checklist, and we'll make sure that all of you get a copy of this checklist after the webinar is over. And I'm just going to go through a couple of the main points. Really, the first thing you need to do is plan your surge capacity and team. And you need to do that by ward and decide how many beds are you going to have, and then what's the design of the team that's going to take care of each of those beds. And an important thing to notice is that we're in a crisis, and we're using crisis standards. So the type of team that you have in the crisis, the quality of care, the amount of documentation that you do will not be the same. And that just needs to be agreed upon and documented. And here you see in this table, we have potential list of units, starting with the ICUs and the wards and the emergency departments. It's often recommended that hospitals also start respiratory units to divert a lot of the COVID patients away from the ER, so the ER can be preserved for people with accidents and injuries or non-COVID conditions. So you might want to consider having a respiratory clinic or respiratory ER. And pharmacy and all the other hospitals or health facility units are here. So you need to document your current bed capacity, your goal capacity, especially considering the fact that you might be converting ORs to ICU units or ward units to ICU units, number of physicians needed, nurses needed, and other healthcare workers. Next slide, please. Now this, the next slide, so Ali or Megan, if you could advance to the next slide. The next slide is a graphic from the American Society of Critical Care Medicine. This is their pandemic team design. And so what you see here is one critical care physician at the top of this team, basically helping to care for 96 critical patients. And so you see there are 4 teams here, and the smaller teams are either headed by a non-ICU physician, or in some settings it can be headed up by an ICU advanced practice provider, such as a nurse practitioner. And then you see we have a second team, which is a ventilation team. So this would include respiratory therapists, advanced practice providers, and your physicians who aren't intensivists. Some of them can be used to do the ventilator management. This is especially a good use for community-based physicians. Then your next level is your ICU nurses, each of which is managing 3 non-ICU nurses. And so this is the team that can be used to handle about 100 patients. And you can design any type of team that you want, but this is just to give a good idea of how we need to change the design of the team to give high quality care to more people. It's important to think about what the critical care physician will be doing here. They will probably be making key decisions about certain procedures, putting people on vents, ending care. And so it's important to define what are those key decisions and key procedures that your critical care physician will be involved in. Next slide. Oops, I think it looks like we missed a slide there. So the other slide that I had was a copy of a protocol. Since there's so much that's new, there it is. So we need to train and provide protocols. So especially if you're bringing in non-ICU physicians or community physicians, you need to make sure that they have the skills and knowledge they need to provide quality care. And this is just one example of actually a medical school-based hospital quite near the Operation Small headquarters in Virginia Beach that's put together a very good protocol of how you take care of the COVID patient. And this type of protocol really helps healthcare workers, standardize care, helps make the care faster, and you can adjust the protocols on a regular basis depending on what you've learned about how to best care for people in your environment, and also based on drug availability. And we always recommend that each version of the protocol should be dated so that there's no confusion over various versions of the protocols. And as I mentioned before, it's really important that people get formal training and also that they get mentoring. And the other important aspects are, the mental health check-ins and general supports, making sure people have the food, the housing that they need, people have the health care that they need. And as you'll see when we provide the surge checklist, there's a whole lot of information there on where to find healthcare workers in the community if you need to expand the number, as well as also looking at issues of credentialing and legal liability, and also expanding scopes of practice during the crisis. So since I only have 5 minutes, I'll end it there, but we'll potentially look at having a webinar just on the issue of health workforce.
So please answer this poll if you would. Looks like testing is available at many locations. This must be high resource countries to all with COVID-19 symptoms, not just those who are hospitalized. We're finding with limited testing in the United States that in many locations, it's limited to those who are hospitalized with COVID symptoms. There's a quarter of our audience here who said that not only were hospitalized patients allowed to be tested, but if they had symptoms, if they were over 65 years of age, or had other comorbid conditions or things that would put them at high risk for mortality, that they were allowed to be tested. Community spread, 88% of the population. Only in 13% was there no community spread. And the current approach in your OR is best described as treat all patients as though they have COVID, and 50% of those who answered, and then use specific patient symptoms and exposure criteria in about 20%. Testing very quickly. The tests that are available are these dual probe PCR tests looking for RNA of coronavirus. The sensitivity and the specificity are both very high as long as there is RNA there. However, early in COVID, the sensitivity may be lower in the 70% range, and that is because often the RNA is not there. And this leads to negative predictive values that are sometimes well under 100%, whereas positive predictive values are very high. So if you get a positive test, it means quite a lot, it's close to 100%. So with testing limited or barely existing, as it I think will tend to be the case in low resource countries, that creates really a difficult situation. We're flying without any sorts of indicators of how we ought to be practicing. So there is guidance that is given by national health organizations in the United States and elsewhere. So these national organizations will give the ministries of health and both state and regional health departments and local health departments ideas on what policies that they should adopt. As you can use what is at the CDC website that's included here on this slide. So when universal testing of patients coming to the OR is not present, then you have to go about figuring out what you're going to do. It makes it very difficult. If you have community spread, that is the key feature here. With community spread in the United States, in most locations, my location, we will treat all patients as though they have COVID. Now, this may be very difficult in terms of having enough PPE, protective equipment, to deal with the situation. And in low resource countries, it may have to be adapted. When you do not have community spread, then looking at symptoms and exposure, travel history, all these things make quite a bit of sense. And if there is no exposure and no symptoms, and treating them as though they have no COVID is a reasonable thing to do. If they have those, then treat them as though they have COVID. Charles, did you want to say anything?
The only thing I wanted to give is just a perspective of what is happening in our country, that we started by just screening travelers and their contacts. Then we moved on to people who had been isolated and those ones who had been put on quarantine. And currently from today, we have started expanded testing. And this was mainly done in hotels where we had people who had been quarantined before and they had tested positive. But we have not started testing the general public. Most likely to start within the next maybe 1 or 2 weeks, because we have already been able to increase our capacity of testing to about 25,000 tests in 24 hours.
Certainly with limited resources, even without testing and even with community spread, there has to be some decisions made on when you're going to use your PPE. And the next section here is going to talk specifically about personal protective equipment. And I'm going to go ahead and move into that. If there's no questions right now regarding the issues of testing. So certainly coming up with particular criteria for when you're going to treat patients in theater as though they have COVID, even though you do not have a positive test, is an important thing to do if you're not going to use PPE for everyone. So let's move on to the next poll. And then I'm going to have Gavin Jones and Luli talking to you about PPE. There's clearly asymptomatic spread of COVID-19 and pre-symptomatic spread. That's the reason that we end up needing to take these precautions even in patients who don't have symptoms. About 3/4 of our audience says that they are either currently or expect soon to be taking care of COVID patients. 85% taking care of patients who need intubation throughout the hospital. And almost 2/3 are taking care of COVID patients in ICUs. Over half have standard paper gowns, half have full body suits, 1/4 are using standard cloth gowns, goggles in 3/4, full head cover, only 40%, half have eye shields. Very few have PAPRs. Reusable N95s, almost half. New disposable N95s, 70%. 16% have used N95. It's becoming very common to reuse and have extended use of N95s. Over half are using normal manufactured surgical face masks and 10% cloth. 2/3 of your practices have cut down your surgeries to only emergency and urgent cases. 16% doing only emergency cases. You can look at them yourself very briefly. As you glance at those, I'm going to go ahead and turn this over to Gavin and Luli and let them start discussing this topic.
Good morning, everybody. What should we know about PPE? Let's see the WHO recommendations. Healthcare workers who are providing direct care to COVID-19 patients has to use medical mask, gown, gloves, and eye protection, which can be goggles or face shield. And we have the second group, personnel that performs aerosol generating procedures, perform on COVID-19 patients, and has to use respirator, N95 or FFP2, gown, gloves, eye protection, and in the case that we don't have a full body suit, we can use an apron as an option. If attention is in the surgical context, we must add the use of surgical caps and leggings. That's WHO recommendations. And so, according to the experience of other countries, what is the suggestion in relation of the suit? The next slide, please. The objective is to avoid possible routes of entry of the biological agent, and when retiring, avoid contaminating or spreading the infectious agent. If possible, we have to wear a full body suit certified as a medical device, like this slide. But knowing that the situation is critical worldwide, we could wear suits made of anti-fluid material. When partially covering suits are used, they must be complemented by a long sleeve gown or an apron. The used clothing must be disposable to avoid source of contagion. If it is not possible, they must undergo exhaustive disinfection. The next, please. And the next. Okay, the surgical masks has an obvious effect as a protection measure against this virus. The mechanism is to filter the air we expel, preventing us from infecting other people. But it doesn't stop us from inhaling the virus. So the best option is the automatic filter respiratory protection mask, the famous FFPR, N95 or KN95. They also filter stop bacteria or viruses that can be transmitted through respiration to others close to us. We can also use the half mask provided with a filter against particles, P2. In this case, they must be cleaned and disinfected according to the manufacturer's recommendation. Against coronavirus, the use of FFP2 is recommended in activities with low or moderate risk, while FFP3 is used when the risk is high. They only can be reused by carrying out a complete disinfection. It's important. Next, please. The use of gloves has a dual effect, protecting the worker and the patient. They can be examination or surgical gloves. Remember that they are only for single use only. The next, please. In relation to the eye and facial protection, we have 2 points. First, one, don't touch your eyes with your hands. And second, do intensive hand washing with soap and water or hydroalcoholic gel. It's recommended to wear goggles that guarantee the tightness of the orbital basins. Face shield is the best option if you are going to perform aerosol generating procedures as long as it's comfortable. The next, please. The optimum will be something like this. There should always be a person helping us to donning and especially doffing the PPE. WHO has made resources available for donning and doffing personal protective equipment. But because of the rush, I think it's better to send them by email. Tell me please who wants, because I think it will be very confusing in this time. Then the next topic with Gavin.
Thanks, Luli. So Luli's mentioned, and looking at the poll, she showed a picture of the non-reusable, well, the regular face mask and the N95 face mask. I was interested to see that 59% of the people on this group use the normal face masks, and 16% used recycled N95 masks. So I'm just going to talk a little bit about first of all, improvising, because it's likely we are going to run out of our face masks. So this is the Boston Children's Hospital that have developed a equivalent to an N95 mask, and it hasn't gone through all the regulatory NOSH certification, but in the absence of us having anything else, it seems like a very good alternative. I will post the link to the screen, but basically you need a regular face mask, either a 3, 4, or 5, depending on your face, with a good fit, the ability to inflate the cuff, and also with the harness hook on the edge. Then also the second piece of equipment needed for that is an inline bacterial or viral filter, a HEPA filter, not the HMEF, as it needs to be a high efficiency particulate filter. And then thirdly, just a couple of elastic straps. And you can click on the link once I've posted it, and it'll show you how to make this filter. Then what we'll talk about, I think, is quite relevant to most of us, is how to recycle or how to sterilize the N95 masks. So there's 4 main ways of doing it that I've picked up in my readings. The first one is time and heat. Well, we'll go to the next slide actually, and just that quickly. It'll show you studies have been shown that the COVID virus can last up to 4 hours in copper, 24 hours in cardboard, and up to 72 hours in plastic and steel. Although there have been more recent studies that have shown the virus to last for up to 7 and even 9 days. So just bear that in mind when I talk about the various ways to decontaminate the masks. So firstly, time and heat. just by placing the mask in a brown paper bag and letting it sit in a warm room for 7 days at room temperature, that has been shown to give enough time for the virus to die. 40 degrees is better than 20 degrees, so a warmer room is better. The second way, which is more practical, is just using oven heat. That'll be at 70 degrees centigrade. My apologies, I haven't written down the Fahrenheit temperatures. For 30 minutes. It's important not to get into contact with the metal surface. So either put it on a wooden grill inside the oven or hang it on clothespins. The third way, and we'll just go into the next slide, is the ultraviolet germicidal irradiation. This is, you'll see on the slide, this has been performed in a number of centers, one of them in Nebraska, where there's an ultraviolet light in a room. The masks are placed hanging in that room, and in some of the rooms they've been painted with a special ultraviolet reflective coating so that those parts of the mask that are not directly exposed to the light can actually receive light from reflection. And lastly, the fourth and fifth slides show hydrogen peroxide vapor and hydrogen peroxide gas plasma units. There's a large scale one and a small scale one where the masks have been exposed to vaporized hydrogen peroxide, and it's also been shown to denature the masks. So in two of the hospitals I work at, they are recycling our N95 masks. One of them is storing it for 7 days in a warm room. The other one is storing it for 4 days in a warm room and then taking it out and exposing it to ultraviolet radiation for 2 days. And I think it's 4 cycles. So, and then what's happening is that they're marking each time the mask is sterilized. They're putting a black mark on. After the 4th black mark has gone on, the mask is then discarded. What's important is that they should not be washed, neither with soap nor alcohol, because it damages the electrostatic attraction layer. So that's just important to remember. Don't spray it with alcohol, because you're going to lose about 30 to 40% of the efficacy. The next subject was wiping down eye protection. So what our Society of Anaesthetists have advised us to do is to wipe down our goggles with any disinfectant wipe, quaternary ammonium chloride, and then spraying it with a surface disinfectant such as ethanol. Again, bearing in mind it must be more than 60%, 62 to 71%, or 0.5% hydrogen peroxide or sodium chloride. And then gloves, we haven't got to the point of recycling our gloves yet, but it has been there has been shown that if you immerse gloves in hypochlorite solution, which is like our common bleach in South Africa and Africa, JIC is a household name, that is also shown to kill the virus particles. The next topic that I think, just looking at the polls, 80% of you said that you're only performing emergency and urgent surgery. And I think that's critical for a number of factors. And the big reasons for delaying is obviously to preserve resources, our PPE, to keep beds available, particularly ICU beds, and also other disposables such as gloves, etc. The second reason for delaying surgery is patients' well-being. And so that's to prevent them from being infected by staff. And that has happened in some of our hospitals in South Africa where they've had outbreaks of staff in hospitals with patients being infected. And then finally, staff well-being. And we can discuss a great deal, and I looked at the previous survey about how people treat patients when they come in to hospital. And I'm having this discussion with my partners in my anesthetic practice. Should we all be wearing 95 masks when we performing semi-elective surgery on patients who have been screened and found to be negative and swabbed and found to be negative? This could still be a false negative if they're in the incubation stage, and they could be asymptomatic, and we could be at risk, which then obviously has a potential downside for the workforce. So, and just lastly, there's a mention of the various tiers of surgery. Tiers 1, which is not life-threatening, and this, as you've all seen, has been cancelled in most surgeries. Then also not life-threatening, but procedures that if they're not done within 3 months could cause or affect the patient's quality of life. And those are being done, but again, the surgeons have to justify to the surgical team in the hospital as to why they should do them. So, and I don't think we can go into the financial implications of not doing elective surgery. It's affected a lot of people in private practice, but I think that's a moot point now, based on the downsides of this virus being propagated. Thank you.
Thank you, Gavin. And thank you, Luli. I appreciate that.
Thanks.
Let's segue into the next subject here, which will be protecting healthcare personnel. There's a question up there about what to do with infected healthcare personnel. We'll try to address that as well during this time. Dr. Kabetu and myself will go through these topics. Charles, I'm going to go ahead and turn this over to you as soon as we do this poll. And you may want to start talking even while the poll results are being shown, but the poll is coming up here momentarily.
Maybe as the poll is being going on, I can make a comment on the surgeries that we are performing now. We have actually put off all elective surgeries except for obstetrics. We are only doing emergencies and urgent surgeries. And this is one way of preserving our limited PPEs. And the other one is to make sure that the hospitals are available in case, hospital space is available in case we have an upsurge of cases. We have been lucky that we currently have only 234 as of today, but we don't know what will happen within the next 1 month. So we are currently only performing emergency surgeries and obstetrics.
So it looks like some of the answers are starting to come in here. The first question has to do with whether or not you have negative pressure rooms, which serves to protect healthcare workers by keeping the virus in the room. The second one has to do with methods to limit aerosol spread that are used in your workplace. The third one has to do with your institution's plan for anesthesia and or ICU trainees during COVID-19 and how you would describe that. So whether or not you have residents taking care of these patients, or you try to keep them away, high-risk staff, do you have them in there or do you try to protect them? And the fourth one is your facility's management of COVID exposure, which pertains to the chat question that we just saw. So you can see in a third of the facilities where our responders are working, there are no negative pressure rooms at all. And in about a third, there are very few and no ORs. And it's really probably only the high resource locations and about a quarter of those that have more than 10 negative pressure rooms in their hospital and only 20% that have both negative pressure operating rooms and regular patient rooms that are negative pressure. So methods to limit spread. 2/3 of you are avoiding positive pressure ventilation, putting up the most experienced laryngoscopist to avoid multiple attempts, and avoiding circuit disconnects. And about half of you are actually using an intubation box. So that actually is a fascinating statistic. Half are using HEPA filters. Less than half have moved to a universal mask policy. Very interesting. I'm going to go ahead and end the poll, and we can be sharing the results. You can look at it while Charles is proceeding.
So my comment on this is that it's very crucial we protect our limited personnel. we have very limited high-level health personnel and we cannot afford to have them either in quarantines, or neither can we afford to have them in the being sick. And so what we are doing is that we are making sure that, first of all, any patients who come with the symptoms, we treat them as if they have COVID-19, and we are also making sure that all patients we suspect that the personnel are well donned and they are being trained. We have been doing training for donning and doffing of PPEs for our personnel. So we are really trying to protect them, and actually it has become law that everybody within a hospital environment has to have a face mask. If you are to go to any supermarket, if you are to go to any public transport, when you are outside your house, you have to have a face mask. And this has been actually made into law, which is punishable by either being fined or being committed to jail, so that you don't transmit the virus, and especially when it is in patients who have no symptoms. So we are also doing the social distancing, and we are treating patients, and especially now that we have started getting a community transmission of the virus, we are assuming that everybody who comes to our operating rooms, they are actually positive. All patients who are coming to our critical care, and the staff have to be having PPEs. We don't have a lot of HEPA, but we have a lot of HMEs. And we are trying to train our people on how to use HMEs so that the HME is very near the circuit as opposed to, and sometimes we even use one on the expiratory limb so that we can be able to protect our staff and our personnel from getting exposed. The issue comes with passive scavenging of waste gas, and most of our operating rooms, actually, they are passive. We have to make sure that we are not exposing it to the corridors where we can be able to expose most of the people who are actually on the corridors. But with the new machines, we know we can be able to do active. The only problem with the using of HMEs is mainly increasing the dead space, especially for the children. Protecting our personnel again is during intubation. We have to make sure that the most skilled is the one who is supposed to go and perform intubation, and especially out of the critical care area in the operating room. We are to avoid positive pressure, and we are also likely to avoid LMICs unless one has got failed intubation or difficult intubation. We are encouraging rapid sequence induction. And once we have put in the tube, we have to make sure that we don't inflate until you have inflated the cuff, so that you don't produce a lot of aerosols that can expose the provider with the virus. And also when you're extubating, you have to make sure that you disconnect the circuit from the patient so that you can be able to have no aerosols again. And it has been stressed that if you are able, one is can use video laryngoscopy is better than just using the direct laryngoscopy. And once you are doing direct laryngoscopy, you have to use what we have been shown as the intubation box, or you can have a facial shield so that you can be able to protect your face to prevent you getting contamination. Avoid laparoscopic surgeries. because pneumoperitoneum can actually expose you to the viruses. Bronchoscopy, endoscopies, and colonoscopies should be limited because they are sources of contamination. The others are to do with the limiting of service spread and cross-contamination. And these policies George will expound more.
Thank you very much, Charles. And I'll add to what you said, that when you use these filters, the HEPA filters are very important, but it's also important to realize when you have children, not only do these add volume, but they add a lot of resistance. And so you need to be very careful. There are case reports that have come in showing that the CO2 is rising substantially, and you need to assist them in ventilation, especially if you're performing spontaneous ventilation with Mapleson circuits. It's very important to assist them and be aware of these large dead space volumes that the HEPA filters may produce, especially if you're not using a pediatric one. It was interesting in the questions that almost half of the audience here is using an intubation box. And it may be very interesting to get some discussion going with those who are using it a lot. The initial comments on those boxes were that the prototypes were not proving to be very useful because there was limitation of arm movement, and you could also have to pull it off all of a sudden because you can't get to the airway adequately and the patient is desaturating. Positive pressure within that system, if you don't have suction, could lead to aerosolization as well. So these are all ways that Charles was going through of limiting aerosolization. At my institution, we are working with a box and trying to work with engineers to redesign that box to get over some of those limitations. And this could be a very important mechanism in low resource countries where PPE is limited. And so I think if we can work to develop some of these boxes, and maybe some of you already have, we may be recreating the wheel over here. It's important to share these ideas, and if we can distribute some of these boxes to low resource areas, because they could prove to be lifesavers. To move on to talk a little bit about limiting surface spread, that is the other way to try to protect healthcare workers, and of course, protect your patients as well. So the big thing here is, of course, hand hygiene and gloves. So this can be a problem in low resource countries, but you need to, in these low resource areas, push hard on your hospital administrators and your Ministry of Health to source these items. Now, we've all read in the news that there's been a feeding frenzy for PPE of all kinds, and we can't even find a bottle of hand sanitizer when we go to the pharmacy. But it's important to try to have your leaders source these things for you. Because these are the number one thing that you can do to prevent spread. And without those items, it makes it very difficult to do a lot of things. So if you know that a patient is actually COVID positive, putting a plastic covering over the machine and other pieces of equipment in your operating room can protect it from becoming contaminated. As we were saying before, it is very common to treat patients as though they have COVID. In many locations, like my own operating rooms, and we don't put plastic over all the machines for every patient that comes through, but we do try to be very careful and break things up into zones. So zone 1 around the patient's head is considered to be a contaminated area. The area that is on the top of your anesthesia machine or your anesthesia cart is considered zone number 2. Before you go to those zones, you want to make sure that you're going there with clean hands unless there is a real urgency for zone 2. So that means if you have put double gloves on, which is common in my institution, that you'll peel off a layer of glove and go to the bag to squeeze it. So we'll have 2 persons in the operating room for an intubation. One is touching the patient, the other is pushing drugs. The person pushing drugs will move over and squeeze the bag, turn on the ventilator, and that person is essentially considered to be staying clean. So they're touching zone 2. Zone 3 is the area that is inside your drawers and where you really want to keep things that are clean. Everything in zone 2 gets thrown away after the case is finished. So you do not want to put things over there to those clean areas. So this helps keep your anesthesia machine clean, the dials, and if you keep things in zone 3, it'll help you prevent wastage. This is not the time for you to be sloppy. You can contaminate yourselves and you can contaminate subsequent patients. The U.S. Environmental Protection Agency has on their website an exhaustive list of effective disinfectants for coronavirus. And the most common ones used are 60% ethanol or 70% isopropyl alcohol. And the one that is available throughout low resource countries that we use in Operation Smile all the time is that diluted bleach solution. So 0.5% sodium hypochlorite, which is what is in bleach, is approximately a 1 to 10 dilution of your standard household bleach that usually comes in a 5 or 6% solution from your grocery store. You want to make sure that you are disinfecting everything, including your anesthesia circuits. So you might say, okay, I put my HEPA filter in and then everything on the other side of it is clean. And that should actually be the case because those filters, providing you're actually using an antimicrobial one, are highly effective. But if you get a COVID patient, I certainly wouldn't assume it to be clean on the other side of the filter. And I would go ahead and change it if they are a patient under investigation, thought to be suspicious for COVID or actually positive. So remember not to bring things like phones, other non-essential items into the operating room because they just act as fomites. It is a big question at this point what to do with trainees. Students, for the most part, I think are staying out of the theaters. They are at my institution. And trainees, we're trying to protect them when we know we have a COVID positive patient. As I said, we're treating everybody like they have COVID and residents are in there doing cases. But when we know that it is truly a COVID positive patient or highly suspicious, then faculty are dealing with that patient. Now, that's not really an option. Places like Jima, Ethiopia, they have 3 faculty and 25 residents, and the residents are going to be key to their efforts. So we recognize that's not possible to do everywhere. Charles, what are you doing?
Yes, George. All our medical students have been sent home, but our residents are with us and we are making them get protection as the consultants. It's only that we have to make sure that all our residents have consultants with them so that at least, first of all, they have the support, and the other is that they are made, one has to make sure that they are following the lay-down procedures, and especially when it comes to donning and doffing.
What do you do with healthcare personnel that end up exposed? That is another question. And really, how are you going to limit their exposure? That's really the subject that Charles and I are talking about, so that you don't need to quarantine and you prevent them from getting ill. Low and middle income countries can really poorly afford to have anybody out, much less for a 14-day quarantine. The Chinese experience, they had about 3,000 healthcare workers become ill in the first weeks of the epidemic, and several of them even died. So, as we were saying, this is a time to be highly careful. They changed their practices. They moved to much more extensive PPE, and they didn't end up with any healthcare workers becoming infected. So it is possible to avoid becoming ill. in terms of sending healthcare workers out on these 14-day quarantines, probably your cheapest and your best bet for this is to avoid the exposures with a universal mask policy. So this will not only keep healthcare workers safe by avoiding the exposures, but it decreases the need to quarantine. So it's worth noting that the Centers for Disease Control has come up with some criteria, and if both the source and the person who if the source of COVID, the patient who turns positive, which could be it could be a patient or it could be a healthcare worker, and the exposed person are wearing a mask, that you can see from this diagram down here that the exposure is considered low. And if it's considered low, there's no exclusion. They're recommending self-monitoring and some supervision from hospital care personnel as well. So wearing masks, a universal policy is very helpful. And finally, having protocols within your hospital, especially for critical procedures, is going to keep to a low roar, hopefully, the contaminations, because many contaminations happen by just our own mistakes, our failure to follow these protocols that are now highly out there in the literature. The next topic is going to be on protocols. Dr. Nabalindo and Dr. Sabeel are going to talk to you a little bit about that. Let me just look into our chat to see if anybody is having any questions regarding protection of healthcare personnel. I see a comment in here that in Ghana, residents are working in the ICU side by side with the consultants, and that's not surprising. I'm sure you don't have the luxury of being able to shield your residents. I don't know whether shielding them is the right idea or not. I'm going to go ahead and turn over the next section here to Suzanne and to Mike, and I'm going to open the poll. This will be a very quick poll on protocols. It's a quick poll because there's only one question there, and it says your facility has developed protocols for which of the following, and you can select all that apply. It looks like it's very common, almost uniform, to have protocols for intubation in the operating room, donning and doffing your PPE. And I see down there at the bottom, more than half even have protocols for which patients will receive intubation. 80% have a universal mask policy already. That's great. I'm going to end the poll and share that and turn it over to Suzanne and Michael.
Yeah, okay. So thank you very much. I will start, and then I will allow Michael to share some of his experiences on the task force for COVID preparation. So we want to talk on protocols and why it is important to have protocols at this time, specifically for COVID-19 management. So basically protocols, like in any other times, as to guide us so that everybody is speaking from the same page. And for COVID-19, this is very, very important for two reasons. One is because we are dealing with a highly infectious agent. So we want to remove variation of in practice around patients who are either suspected to be COVID positive or those who are already confirmed to be positive. Because if we have variation in practice, then you are at a high risk of having gaps where people can be infected. Then two, it also boosts the confidence of the teams. When you have people doing things per protocol, then you have the team having confidence that they are doing the right thing. Unlike when you have one person in a team doing the right thing, but they're afraid because the next person is not protecting themselves or protecting the team. And also important is because you're having, as you've seen in the earlier presentations, you're having people working in new environment, people who have not been in ICUs coming to help in ICUs. It's not possible to teach them what we do every day. So when you have a protocol, then they can easily refer to the protocol to know what is exactly should be done for a particular situation. So what are some of the protocol areas that you might require to look at, or you might develop in your institutions, most of which we have developed here where I work and basically for the country. One, you have the infection protection, prevention and control protocols, the IPC protocols. These probably are already available in hospitals. Things like sanitizing hands, hand hygiene. Those might already be available in your various institutions. So what you probably need to do is to work with those, particularly the IPC departments, to bring out those protocols so that they can be available for people to use and train people, remind people how these particular protocols are used. Other areas of protocol use could be review of patients. This is review of patient protocols. This is very important for those of us who are practicing both in ICU and in the OR. Yeah, so we find that in most of the low and middle income countries, the anesthesiology still does a lot of ICU, they're called into the emergency departments to see patients, sometimes even assisting with fixing IV lines. So you do not want to be, if you are either dealing with a situation where you already have COVID positive patients in the hospital, or you have community transmission already happening where you are treating everybody as positive, then you want to have protocols on how you're going to move from your department for a consultation into the other departments. And at this point, like in what we have done is trying to have as much as possible telephone consultations where possible, where you can guide people in the various departments without you having to walk out of your department. And two, what to do when you have to walk out of your department. Maybe you are going to the emergency department, or you're going into the wards to see patients who might need a consultation from ICU. So we developed a protocol basically to say, if you're going to see patients out there, what is the minimum that is required? Do you need to, what type of PPE do you need to have? And even when you are there, when the patients require particular procedures, what should you have available for you to handle these patients? The other review of patient protocol is how are we reviewing patients, the preoperative review of patients during this time. In most of our institutions, as Dr. Charles Kabetu said, we are down to doing emergency and urgent cases only. But even these patients still need to be reviewed preoperatively. So what we've done is that initially it was practice to go and see these patients in their particular wards, but now we are asking for the patients to be brought, and you are seeing them earlier in the OR, reviewing them in the OR, so that you decrease the traffic between people moving from the OR to the wards and coming back to the OR. Then there is the operation room organization protocols, and this you will not do as anesthesia or ICU practitioners only. It requires the whole team with surgeons and the nurses and the hospital management. So this needs to happen quite early, so that especially in institutions or in countries where you cannot have dedicated hospitals being COVID hospitals, where you'll have COVID patients in the same hospital with other patients. So you have to have protocols on how you will handle to wall off part of the hospital as the COVID side, including your ORs. So that requires organization with all team players. And that has to be done early. On the particular teams, again, like for anesthesia in our hospital, what we did, we have a COVID rota, whereby people who are doing the emergency cases every day do not have to handle the COVID patients. So they'll continue with their work, and if we are alerted that there is a COVID positive patient coming into the OR, then there is a completely different team that is coming from the nurses, the anesthetists, the surgeons. Then another area for us is the intubation protocol, which has been discussed with the various panelists a bit. So the protocol, again, will address for intubation from discussions going on globally. It's now agreed that rapid sequence induction is what we need to do, and everybody has agreed with that. So then use of PPE, with all the limitations of having not having enough PPEs globally. And then use of ETT versus LMA. For the use of ETT versus LMA, I'll probably let Mike comment on that when he gives his views. So for my hospital, or rather my facility, and basically what is happening in our country is that you have the protocols for intubation, which basically insist on safety for the practitioners. So preparing is very important, and there is a checklist of what you should check is available before you actually step in to do intubation. For the use of the PPEs, all involved in intubation should basically be fully donned, because it's an AGP, an aerosol generating procedure. But what if you have limited PPEs? An example of what has happened, we have not, in my institution, we have not had surgery for a confirmed patient, but we have had several surgeries for suspected patients. Those are direct contacts to people who have been confirmed positive. So initially, everybody, surgeon, the nurses on the team had PPEs, but we started realizing that the PPEs were running out very fast. So some leeway we have made is that you can have the senior most one of the anesthesiologists having fully donned, and then you have the surgeon or the scrub nurse who is also fully donned being their assistant during intubation, so that you avoid having two anesthesiologists fully donning. Again, that has a challenge in the event that you get a difficult intubation, then you probably need another experienced anesthesiologist with you. So what we've done is that there will be an anesthesiologist who will stay out of the room, one anesthesiologist with the surgeon who is going to be in the room, and or the scrub nurse do the intubation. But in case of difficulties, then the second anesthesiologist can don and come in. Then you have the pediatric patient, which is a bit of a challenge, because our standard practice is inhalational induction. So people are having to learn how to do IV induction. So you try as much as possible to avoid crying and use IV induction as the primary way of inducing the patient. So again, use of preoperative sedation comes in handy here. And there are several drugs, ketamine orally, midazolam orally, that has worked well for us. So while the patient waits to come in, they can be given those particular drugs orally, give enough time so that they are a bit sedated when they come in. You can be able to put an IV line without them crying. But again, quite a challenge for most of the practitioners, especially those who don't deal with children on a daily basis. So another area of protocol is the extubation protocols. Again, avoiding coughing is the key word. You want to have protocols to guide people exactly on what to do. PPEs, they should be they should still be donned in their PPEs, and they should try as much as possible to avoid coughing, because that is, again, a highly aerosol generating procedure. Then you have the recovery from anesthesia. For COVID positive and suspected patients, you want to recover them in the OR. So for our place, we've done recovery in the OR, and then you move the patient straight back to the isolation wards where they had been brought from. And if you are having your ORs attending to both COVID positive and non-COVID in different areas, then the rest of the patients then can be recovered in PACU as usual. So you want to completely protect the PACU and the people there from the COVID side. So the patients with the COVID positive or highly suspected then go, recover in the OR, and they go back straight to their isolation wards. Lastly, maybe to comment on other protocols. Most of the other protocols will probably be the National Ministry of Health protocols, which you have to look out for. And as Dr. Kabetu has said, for us, the universal mask policy has come in, and it's being enforced very strongly. So, and part of our work as practitioners is to keep on reminding people in the hospital to use masks. You know, there is the universal, but there's the wrong way of wearing masks. Sometimes you find relatives of patients who actually are not following that once they're within the hospital. So when you pass around and see people without that, is keep a reminder that that has to be enforced fully to protect the healthcare workers and also the patients. So I will give it to Mike to make some comments and additions on what I've said.
Thank you, Susan. That was excellent. So what I've been doing the past month, and we're actually probably past the height here in Nashville, but I was basically put in charge of the COVID response at my hospital, which is a hospital in the middle of center of Nashville. But there's a few points I wanted to make. You're essentially running, and I think Susan alluded to that, you're basically running a parallel healthcare, two parallel healthcare systems. You're running a system where you're taking care of a COVID response, and you also have issues where you need to continue to provide urgent and essential healthcare to a population. Some of the things I found that and protocols are really important because basically they communicate that you are organized, concerned, and that you have these and you're taking these processes seriously. What I found worked pretty well is daily rounds. If you're a physician leader at your institution, to all the sites, that really reinforces that. And then basically making the commentary: what do you need in terms of PPE? What do you need in terms of resources? And people be very direct and frank about that. We've also had every day at noon, we've had town hall meetings in an open space where all the physicians at the hospital come together. We stand in an open, and we actually go over the progress we're making. We go over the initiatives. We go over new innovations that we're doing to treat people. We publicly celebrate, we've had about 35, 38 patients hospitalized with COVID. Probably now about 20, 22 have gone home. We've had a certain cohort of patients in the ICU, and they've actually done, for the majority, have done very well. So we celebrate these victories. I found having a PPE czar at the hospital was very useful in terms of conserving resources. And one of the last points is there is going to be a post-COVID world. So you communicating to your staff that their safety is your utmost priority, is the highest priority for your institution, is going to gain institutional loyalty. The things that can go wrong when you're in the middle of it is people lose faith in an institution and don't show up. And luckily that has not happened to us. So those are my brief comments.
Yeah, so maybe I can just make a comment about the residents. We basically, at my institution, university, we are the biggest anesthesia school. So what we did very initially for protecting our residents is because we do both ICU and the OR. So because we had gone down to emergency surgeries, we basically divided the team into two, those who are covering ICU and those who are covering the OR. So we made a decision that the residents will stay in the ICU because currently for this particular hospital, we are not receiving COVID positive patients to our ICU because there's a COVID hospital where that is going to happen unless now we have more numbers. So it's only the consultants, the attendings, and the non-physicians who are qualified who are attending to COVID patients for now. So we have completely protected the residents, although they might get exposure when they are reviewing patients from ICU, and that we have come with the protocols of what PPEs they should use in those incidents. Thank you.
Thank you to both of you. I want to ask a quick question. So we hope to be making this video available to others who have not been able to be online with us today. We also are thinking about putting together a Google Drive where Operation Smile participants or participants at this meeting or those who signed up to be here who can't be here could be invited to. And I wonder if you found particular protocols that are helpful in low resource countries rather than having to recreate the wheel and come up with their own protocols. It may be useful for them to adopt some of the protocols and adapt them to their own localities. I sent out the APSF protocol to everybody who's in this meeting room just a few minutes ago, and that is for managing the airway of a COVID positive patient. There are many of these. If you found anything to be particularly helpful, if you could share that with us, and maybe you could share those with me, and we could add those to a Google Drive. Any comments on any protocols that have been particularly helpful, or ones that Suzanne, you may have adapted at University of Nairobi?
So we initially, maybe 4 or 5 weeks ago, before the COVID talk came up, we as a department at the university made some protocols which were basically to be used by the residents, but now they're being used by everybody. And then too, the Kenya Society of Anesthesiologists has come up with protocols to guide all the anesthesia providers. So I believe I can find a way of sharing those after the meeting, yeah.
In terms of protocols that you've seen, there's a question out there from Colleen Krug, and she's wondering whether or not rapid sequence intubation is indicated for everybody. Is inhalational induction absolutely contraindicated? And are laryngeal masks ever okay in this era of COVID?
So we have a separate children's hospital, and I, consulted with the pediatric anesthesia providers there, and they are doing inhalational inductions there. In the regular operating rooms for adults where we're doing emergent and urgent surgeries, people are essentially doing rapid sequence inductions with video laryngoscopes. One of the things is we actually have the staff outside, except for the anesthesiologists, and we do a care team model in the CRNA.
So certainly, at our institution, we will still do an inhalational induction if it's not a known COVID patient. I don't think we would do one in a known COVID patient.
Right.
But we're doing them, but we're trying to avoid them. So a heavy sedation, I think Suzanne mentioned, or somebody mentioned before, a heavy sedation, you can usually get an IV in without crying. You're trying to avoid aerosolization. We're running a little bit behind. I'm going to move on here to the final topic, which is ICU management. And I think that probably is of a lot of interest here. 2/3 of our participating group does practice in the ICU. Things are rapidly evolving, both in terms of trying to figure out how to prevent intubation and how to manage these patients. We may have some other individuals who are in the chat room here who will want to comment on that. We were trying to get some input from some of the Swedish anesthesiologists, and I did have some chats earlier this morning, but we're trying to learn a little bit more about what are the problems that happen when using anesthesia machines for ventilators. And this is something that may happen quite a bit in low resource countries. I'm going to go ahead and throw up the poll for ICU care. So the first question deals with, is the ICU at your hospital currently repurposing the anesthesia machines to serve as ventilators? And very interestingly, almost 40% of the responders have said that that is occurring at their institution. And 20% don't know. What methods are currently in use at your facility for preventing patients to need intubation? And 3/4 are mentioning that CPAP and BiPAP are commonly used. Proning is being used at half. High flow nasal cannula at 2/3. I'm going to go ahead and end this poll, Ben, and turn it over to you. Here's results for everybody to look at while Ben is talking.
Hi there, Ben Moses. I'm the anesthesiologist intensivist in the surgical ICU at University of Virginia. And as many of you have already indicated, much of the information that we're working with now, there's this onslaught of publicly available resources. But for me, a lot of what I'm using and what I'm learning is coming from those that I trust, that I work with at institutions around this country and around the world, based on their experiences. So some of the things that I'm going to talk about today are going to have to do with those experiences that I have had and that my colleagues have had. Some observations, given that I've had the benefit of watching everybody else's talks so far. There's one thing that we are using in our hospital. In addition to developing protocols, we actually have the benefit of a simulation center. And that's something that all the members in our ICU teams, as well as our OR teams, have the advantage of using. Even if you don't have a center for simulation at your disposal, I would strongly encourage any protocols that you have developed in your institutions or any that you're getting from this forum to practice before actually taking it to direct patient care. I can tell you I had the experience in doing a simulated intubation of having things pointed out to me that I was doing wrong, that were potentially increasing my risk of self-contamination or contaminating the area. And given how limited our resources are even here, and even moreover in low and moderate resource areas, the importance of practicing outside of a contaminated area first, I think is something that will be multiplicative in terms of its usefulness at the bedside with patients. In ICU settings, there's some issues that have come up that I wanted to talk about. So typically, I should say historically, the concept of proning patients who have ARDS, advanced adult respiratory distress syndrome, is typically in people that have been ventilated already and are prone to open up the posterior lungs to ventilation. We're actually seeing a lot of success, and this is anecdotal at this point. There isn't anything published to support this, but it is very, very common now to be using proning in people who are not yet intubated to improve oxygenation. One thing that I've heard from many of my colleagues that is a difference, very different approach to respiratory failure compared to other types of respiratory failure seen in the past, is avoiding intubation. And I think a big reason we're doing that, trying to avoid intubation, one, the process of intubation puts a number of healthcare providers at risk, and we are by far the most limited resource. And two, the outcomes of people who are requiring mechanical ventilation is much worse with this particular respiratory syndrome, at least in adult patients, than it is with other types of respiratory failure. In some locations, they're seeing as much as 70% mortality in patients that are requiring mechanical ventilation. So actually, though we don't know whether this is causative or associated, we do know that people that stay off a mechanical ventilator tend to do better. I noticed that a number of respondents, it looks like about 65% of people who responded to the poll indicated using high flow nasal cannula oxygen. And that's actually one thing that we're trying to avoid in our patients. The concern is that the use of higher flows actually can cause aerosolization of nasal secretions, even in people that aren't actively coughing. And that could be of great concern to the other healthcare providers in the room. Having worked, albeit briefly, in a low-income, low-resource hospital where patients are frequently cohorted together in one room, I think it's very important for us to talk briefly about the ways that we can minimize exposures. And here in our hospital, one thing that we have done is designated wards as being warm areas, such that people who are under investigation or people who are known to be positive with the disease are isolated on one floor of the hospital. And we've actually kept both surgical patients and medical patients on that one floor to the best of our ability. Similarly, people, once they're in and needing an ICU, they stay on the same floor and go to an ICU on that floor. Not everybody, not every hospital has ICU beds or has the luxury of having multiple ICUs on different floors. But to the best of our ability, we are trying to keep people isolated to one area. To that point of isolation, another thing that we've instituted in our hospital that is very challenging emotionally, both to the patients and to the healthcare providers, we have limited, almost completely done away with visitation in our hospital. And that is to avoid unknown exposures, people coming in from the community that may be sick and not know it. It also is to decrease the chance that when they come to visit a family member, they are actually exposed to the disease while they are here in the hospital. Let's see, there are a couple other things that I wanted. Oh, okay. So this is just a couple of practical points that I'd like to make. Those of us who work in ICUs deal with people who are at risk of dying and frequently are called to assist and support somebody who is in the act of dying. Here we would call it a code situation. It is very important, and this is something that again, going back to the simulation or practicing first, it is very important that people don't rush into a room to support and assist somebody who is actively coding without donning PPE appropriately. You may be able to save that person's life, but if it comes at the cost of you becoming infected and then no longer being able to care for other people, you are greatly reducing the effectiveness of our limited resources. In order to ensure this is happening here in our institution, we actually have people that have been designated as donning and doffing coaches. That's one of the policies that we have here. If you have the people to do it, if you have the extra people, it doesn't have to be a nurse, it doesn't have to be a physician, It can be a student. It can be an otherwise untrained worker, but somebody who can stand as an observer and ensure that you're correctly placing your PPE prior to entering an area where there's an infected patient, and then making sure that you are doffing, that you are removing your personal protective equipment safely without contaminating yourself when leaving that area. I think those are very important points to be made. As far as ICU nurses, we have a luxury here of having a very low nurse to patient ratio, meaning we typically have no more than 2 patients for any ICU nurse. Additionally, our nurses in the intensive care unit have specialty training in critical care management. In order to multiply our nursing staff quickly, as far as our ability to have them assist and support in the ICU, we have non-critical care nurses shadowing in the ICU outside of the COVID area. So we have people coming in and actually learning basic skills. And I think one of the other presenters alluded to that, making sure that we're using the people that we have, even under the supervision of other specialty trained critical care providers. One of my colleagues who has been working in New York City has said that they've actually gone to a 1-to-4 ratio even with their sickest patients, because they have such a deficit of ICU nurses compared to the number of patients that need ICU care. And I think that's something to keep in mind, that we have to use what we have. As long as we're focused, and everything, I think everybody comes back to this, is we're focused on protecting ourselves, using appropriate PPE, making sure that we're washing our hands, not touching our faces, those things. There will come situations where we have to expand to more patients as far as the interventions that we're making. You wanted to talk about the machines?
I do want to talk about that, and I do want to say as well that this meeting is scheduled to close at 11, so it could shut us off abruptly. And so I don't see any questions having popped up yet regarding the ICU topics. If you want to comment on anesthesia machines, I could pass along to everybody some of the information that I've gotten from the Swedish anesthesiologists who are working in ICU, and I'm curious what you might say about this as well. But they say that the secretions of patients in the ICU can be really tremendous, thick secretions, that they've had a number of patients who are having even cardiac arrest related to these inspissated secretions. So we talked about trying to avoid aerosol, and having inline suctioning is one way to do that. Having inline suctioning may not be possible in low resource countries if they don't have the devices to be able to do that. But what has happened, I think, in Sweden, from what I have been told, is that using anesthesia machines, because of the lack of humidity, has led to much more inspissated secretions and many problems with the need to suction. And they have moved recently to trying to place an inline humidifier, I think similar to what you might do with albuterol neb, placed in between the tracheal tube and the HEPA. And that has, they say, done a lot in order to try to cut down on these secretions. They were trying to avoid suctioning them because of the aerosolization, but they have now decided that that is better than having to run in there and suddenly change a tracheal tube in an uncontrolled situation. And I think you can make up your own mind on what you're going to do with that. Or if you're going to place inline suction in that location, you worry about aerosolization. One thing people talk about is putting a clamp on the tracheal tube. If the patient has a paralytic on board, you could clamp the tracheal tube while you're disconnecting and not risk aerosolization. So if you have any experience using anesthesia machines or have read anything about that and want to share it, we have only about 1 minute. I hope it won't cut us off, but if it does, I want to say thank you to everybody for participating here. to all the audience and especially to the panelists. And I did allude earlier to there being potentially a recording as well as a Google Drive, and you'll get further communications. Thanks.
Just in case it doesn't cut us off, there are some things that I would like to continue with, if that's okay, George. A couple issues that I think will come up if they have not already. Triage of resources, resource allocation is going to be a problem everywhere. And having a plan for it, having a protocol for how you're going to allocate resources, I think it's better to have a plan ahead of time than to wait until you're out of resources and decide who gets what. One of the issues that is already a daily concern in low-income, low-resource areas is the availability of critical interventions to people is frequently based on their ability to pay ahead of time. Here in Virginia, luckily, that's not something that we tend to use as part of our triage process, but I think in many areas, people are not even going into the ICU unless there's evidence that they can pay for the services that they're going to get there. And unfortunately, I think that remains the case right now, even with COVID positive patients. One thing that we've done here that I would recommend at least considering in other places is addressing patients' code status at the time of their admission to a COVID unit. So our presumption for most of our patients is that in the event they suffered a cardiac or respiratory arrest, they would want to be resuscitated. And so we have orders addressing that from the time any patient is admitted to the hospital. Given the observed low positive resuscitation rate in people that are dying of COVID, there are some people that are electing to change their code status to DNR based on being COVID positive in the context of any other chronic illness. And I don't mean to sound overly dramatic about it, but it is something that having this discussion be kind of standardized for this patient population, especially when there's limited contact with family members, may alleviate some of the distress around end-of-life issues. Just to talk a little bit about what George was saying about the use of anesthesia machines as critical care ventilators. We haven't done that at UVA yet, at my hospital yet, but we have a plan for doing it. There are hospitals in the United States that are doing it quite frequently, and my colleagues who have been doing it here have noted especially a difference in addition to the things that George had mentioned, higher driving pressure is required when using anesthesia machines, especially in people that were already requiring high levels of positive and expiratory pressure. And at times higher flow rates and higher PEEP just to maintain oxygenation. When the same patient was then converted over to standard ventilators, they required less support. So it does seem that even though we're able to use them, that there may be a difference in how people's compliance is affected when they're on anesthesia machine ventilators instead of instead of ICU ventilators. Of note, many of the lower resource areas may or may not actually have what we would consider standard anesthesia machines in their operating rooms right now to actually convert to ventilators in the ICU. Additionally, the ventilators in the ICU may or may not have the types of modes that we would usually consider as being appropriate for people with poor compliance or poor oxygenation related to ARDS. And so some of these recommendations that we're making may not even be applicable at this point. One issue that has come up here is the use of SOFA scores for triage, and whether or not that is something that can be broadly applied. I know that that's something that is used frequently in research and literature to identify people that are at highest risk of dying during their hospitalization. but I think that any scoring system so far has been very difficult to use. So making sure that there is agreement between providers in your hospital system about how you're going to be doing triage is probably the best way forward, instead of relying on a single number or single score. George, thank you so much for allowing me to continue a little bit there. I hope everybody was able to listen in.
Thank you very much, Ben. I'm glad we were not cut off briefly. I don't know if I see Peter Riddell is in the audience, if he wants to comment at all on the Swedish experience, or if I summarized it adequately. But Peter, feel free to unmute your mic and comment if you would like. And otherwise, I'm just say that there certainly is a possibility of having further discussions. This, like everything we do in Operation Smile, we say is a work in progress. And so this is just the first experience with it. We're talking about having other sessions for other subspecialties. And we would take input on what sort of topics you'd like to see discussed. We can bring in other panelists in order to try to address that with some expertise. We're all trying to figure out things on the fly. And it's been very good to be able to share these things with you. And I know there's a lot of you out there with experience as well. A lot of this may not be new to you, but I hope that we've been able to disseminate some important information, especially to those in low resource countries, and especially to those who have the pandemic just gearing up in their location. So thank you again to everybody for being here, and to the panelists who made this a excellent session. Stay safe, everybody.
Thanks, everybody. That was great. Thanks, George, for coordinating, and Ellie for the background work. Much appreciated. And I'm sure there'll be more discussions on some of the finer points.
Yes, thank you.
Thanks, everybody. Have a safe.
Ellie Anderson, thank you, Megan Kenyon. Thank you to everybody who has been working to make this come together.